All right, so welcome to this panel on progress in equity and inclusion through research. This panel has been held actually every year at this conference. It's to show how much interest there is in this topic across SUNY, which is wonderful. So first, we're going to start by kindly asking each panelists to present themselves. Just say who you are and what's your institution and your academic field. Thank you. So you can start, Shunwan. Yeah, we go from left to right and top to bottom.
Okay, thanks, Isabelle. Okay, I'm Xunhuan. I'm a second year PhD in geography at the University of Buffalo. And my research fields is falling in economic geography and political economy and political ecology. So basically, now my work is trying to focus on to see the Confucius understanding of justice in China's energy transition. So trying to speak back to the just energy transitions in the field of research and to bring back more like un-Western philosophies of justice.
Mm-hmm. Thank you.
Yeah. Hi, I'm Sabina Hirschfield. I am faculty in the School of Medicine at SUNY Downstate Health Sciences University in Brooklyn. And I've been conducting e-health interventions for over 20 years with sexual minority populations and gender minority populations. So Michael and I will be describing some data from this particular intervention that's still in the field.
So Michael?
Hello, yes, like Dr. Hirschfield said, we'll be presenting on a similar study focused on sexual minority men in this case. But my name is Michael Daly. I'm a second/third year medical student at SUNY Downstate.
Thank you.
Hello, my name is Jillian Shudo. I'm also here with two of my other group members who aren't pinned, Erin and Kellen. We are from Stony Brook University on Long Island, New York, and we're second year speech language pathology students in the School of Health Professions. And our research is focused on the impact of stuttering support groups on the confidence of adults ages 18 years and older and their confidence to participate in social situations.
Thank you. So now we're gonna have each panelist present the research that they have submitted as an abstract to the conference. And again, we're gonna start by Shunhuan. So you can share your screen if you want. Thank you.
Share my screen. Can you see my screen?
Yes, we can.
Cool. Okay. Hi, everyone. I'm Xunhuan. I'm PhD in geography. And today I just want to share my very preliminary work on the Confucian sense of justice in China's solo-led regional development, trying to speaking back the dominant Western ideas of rules-and justice in the energy justice literature. So this is a picture I took 2 years ago in the northwestern part of China, the Kubuqi Desert in Inner Mongolia, and it shows a very big solar base in the desert. The Kubuqi Desert is the 7th largest desert in the northwestern part of China. And when I was conducting my field work in this desert, I was shocked by this size of the solar base. So I went to, I interviewed a manager about in the solar companies. So he told me that the Chinese government is trying to use the solar transitions to solve the uneven development in China. That means they are trying to use the solar panels and the expansion of solar facilities to help the Western left behind regions and trying to help them catch up with the Eastern coast of China. So that's why I want to study the solar transition. But before we look at the empirical results, first of all, I want to compare these two kinds of justice in the current literatures. One is the John Rawls' understanding of justice and equality. The other is the Confucius ideas of justice. So John Rawls is American philosophers, and he has developed his own series of justice in the 1970s. He wrote a very famous book, A Theory of Justice. So in his book, he's trying to build his theory of justice on two principles. One is liberty, the other is equality. So Rawls want to seek the justice through the social institutions and laws. That means in Rawls' understanding, how to achieve justice is like we need a fair social institutions and laws to create the justice. And Rawls' understanding is built upon the liberal democratic societies, and his kind of justice is more reasonable and practical because although he accepts the inequalities due to the differences between people in practice, but he thinks we can build justice and equality through a fair system of social institutions. While Confucius' understanding of justice is more rooted in the traditional Chinese societies, especially in the feudalism. And Confucius proposed a concept of Zen, or we can understand is humanism or benevolence. So he calls for that how to achieve justice is we can turn to a human state to solve the inequalities or injustice in practice. But his kind of justice is more ideal and non-practical, because we know that the state might be more expand their power and controls over the territories instead of to solve the inequalities and injustice in the practice. So but Confucius' idea of justice is deeply rooted in Chinese societies. So if we want to understand the China's energy transition, we must get this Confucian idea to have more situated knowledge of justice. This is the two figures about China. The figure on the right side is about the solar transitions in current China, and it depicts this geographic patterns of solar panels. And you may see that the red dots are the hotspots or the geographically concentrated clusters of the solar panels. And you may see that many of the solar panels are highly distributed, are largely located in the northwestern part, which is the left behind regions of China, while the eastern coastal part, the Wales provinces are installed little solar panels. Why the Chinese government did this? Because they want to solve the economic divide within China. So you may see the figure on the left side. It depicts the economic divide within China using the nighttime lights data to show. So the darker blue dots depicts the less developed regions, while the lighter dots, like the yellow dots, depicts the whale spots. So there's a clear divide between the eastern provinces and the west and north provinces. So the Chinese government is trying to using the solar transition to address the existing geographic uneven development. But whether it can achieve this goal in practice, so I did some empirical analysis using the some spatial orographic models to examine the empirical results. And I divided the solar panels into two different kinds of solar panels. One is RESPV, which is the residential solar, like rooftop solars. These are distributed solar systems. The other is the non-residential solars. So basically, on the large-scale solar bases, they are more concentrated, they are more centralized installed, like the large-scale solar bases in the northwestern deserts. Then then I also divided the regions into two types of regions: the left behind regions and the non-left behind regions. Then run the regression models and get the estimation results. So in the estimation results, you may see that the residential PV, the residential solars have the significant positive impact on both economic development in left behind regions and non-left behind regions, while the non-residential PV has a significant negative impact on the economic development in both two types of areas. So that means residential solar will have the positive impact for local economic development, but the non-residential will have negative impact for local economic development. So if we look at the two types of solar panels, you will see that the geographic patterns actually show the adverse impacts. So residential solar panels are largely distributed in the eastern coastal part of China, which are Wales provinces. But the non-residential solar panels are highly distributed, which has the negative impact on local economic development, are largely distributed in the northwestern part or the already existing less developed regions. So that means the current solar-led regional development needed by the Chinese state may exacerbate its existing regional inequalities between the western left behind regions and the eastern non-left behind regions. That means it will not achieve the Confucian sense of justice in the Chinese government's terms. So basically, the Confucian sense of justice also accepts social and economical inequalities in reality and calls for a human state to address injustice and uneven development. But the current solar development needed by the Chinese state will not achieve this Confucian's understanding of justice, because and more non-residential solar should be deployed in its western left behind regions to help them catch up if the Chinese government want to achieve its Confucian sense of justice. Lastly, I think we need a more situated understanding of justice and equalities when we discuss about DEI or justice, because we need to know what kind of justice does this farmers or local residents perceive, and what are their understanding of justice. So based on their situated knowledge is more important to help us to understand the justice and equalities. Thanks. That's my research.
Thank you. Please share your screen. Okay, perfect. Thank you very much. Next, Sabine.
Oh, sure. Actually, it makes sense if I go before Michael, because the data I will be sharing is from the screener. Can you see that?
Not yet.
Oh, what did I do? I work in technology, and yet I always, okay, wait, where did I go? Cheers. Let me see. Did I do this right?
Yeah, it's starting now.
Oh, good. Okay.
Yeah, that's
so
good.
this is a NIDA funded study, which is the National Institute on Drug Abuse. And we are in the 6th year of this study. Paula Pedrani was supposed to present, but she was unable to, so I'm doing that in her stead. And she worked very hard on this research, and she is interested in looking at the severity of methamphetamine use. Oh, wait, I'm not sorry. It's not, there we go. Okay, she is looking at the severity of methamphetamine use and adherence to HIV medication, which is also called antiretroviral therapy, or ART, which I'm going to now use instead of saying HIV medication. So she was looking at associations between the level of stimulant use and how adherent to ART this population is, because elevated HIV viral load means that you have faster disease progression, but it also means you can transmit HIV. So the aim of this particular analysis was to inform HIV care strategies and looking at the association that I just mentioned. And this is with a nationwide sample of over 7,000 sexual minority men living with HIV. And so we had maybe 19 or 20,000 people who completed this online screener survey, and it's anonymous. And the people who are in this particular sample are people who would be included for the intervention. But I will show you the inclusion criteria in a moment. So I think, I'm trying to think what years, this must have been 2020 to 20. Well, we just closed recruitment a few months ago, but we started recruiting several years ago. And this is just talking about how we did our analyses. And the inclusion criteria for this particular study is people had to self-report as a cisgender man, age 18 or over, able to read or respond in English, reside within the U.S. or U.S. territories, identify as living with HIV, and to either show by a Zoom call or to upload a photo of their ART prescription bottle, and then to self-report their adherence to their ART. Hold on, I have this bars, of course, right in front of what I'm trying to say. So there were actually two ways that we measured ART adherence. There was a visual analog scale where it would online, you can kind of move the scale to between 0 and 100% of how many pills you took in the last 30 days. And meth use severity was calculated using the NIDA modified assist, which is a screener that's considered valid also for clinical implications of substance use. And we asked about a number of substances, but we were focused on stimulants, namely cocaine and methamphetamine. And so the scoring ranges show you mild, moderate, and severe use. And this is for past 3 months, the NIDA modified assist. This is not moving. I'm having technical difficulties here. I don't know why it's not moving. Let me see. Let me hit this now. Okay. So I will give you a brief overview of the sample characteristics. Median age was 39. The majority of the sample was white, 47%, followed by 24% Latinx, 22% Black or African American, and 7% other race or ethnicity. In terms of sexual identity, almost 80% identified as gay, followed by bisexual or other sexual identity. 89% were born in the US. And we asked about other substance use. Everyone used stimulants in this study, namely methamphetamine, which was our focus. But in the past 3 months, we had 70% reporting alcohol use, 60% cannabis, and 20% cocaine. I'm going to skip over the analyses, except to say that if you look at the bottom where it says methamphetamine use, mild, moderate, and severe use, if you look across at the full sample, you see that there's a trend in the severity of use and the likelihood of being non-adherent to your medication. And that holds across race and ethnicity. So just to summarize the results, in the last 30 days, the likelihood of suboptimal ART adherence was associated with increasing severity of methamphetamine use, being born in the US, also using cocaine, and reporting in either a Latinx or Black African American race. And a lower likelihood of past 30-day suboptimal adherence was older age and drinking alcohol use. I'm sorry, and having alcohol use. So we talked about how we did stratify models by age and severity, but we found that across, as I said, across each race and ethnicity, we found this consistent pattern of stimulant use and suboptimal adherence. So some of the limitations include that when you do a screener survey online for a study, you really should focus on your study inclusion criteria. We try to add a few things so that we can find new areas of research. And so, we were able to develop this research question for the medical student, Paula. And, we also were really screening on sites where men are meeting other men. And we asked for men who are living with HIV and who use stimulants. So we had a skewed sample that were moderate to severe users. However, the findings support the need for integrated, culturally competent care and substance use screening within HIV and primary care settings, because a lot of people aren't discussing one or the other healthcare issues they may be having with separate doctors. And it's my guess that a lot of people don't talk about their substance use with their providers. So, the next steps are to build these behavioral and biomedical interventions that address actual reductions in stimulant use, which will help with them navigate their adherence to medication. This is some of our work that was cited in the talk, and this is where how the study was supported. The MPIs, or the multiple principal investigators, are me, Doctors Carrico and Horvath. And Paula's work was supported by a 2023 SUNY Downstate Alumni Research Fellowship. And finally, the co-authors of an article that we are working on are listed below. And that is it.
Mm-hmm. Thank you very much. Very interesting. Next, Michael, you have the mic.
Michael,
Michael,
you're
muted.
Yes, I should be good now. Can you guys see my screen?
Yes, we can. Thank you.
All right, so hello everybody. My name is Michael, and today I'll be presenting on the association between psychological distress and emergency department utilization among MSM, or men who have sex with men living with HIV and a stimulant use disorder. Some of it will be similar to Dr. Hirschfield's, but our research question was different. So I'll start with just the basics of where our study started, which is first, I was curious to figure out what a syndemic was and how it played into emergency department use. That's going to be the big picture of the study. So what is a syndemic? The syndemic theory is defined by co-occurring issues like depression, trauma, substance use, anxiety, and other things that I'll discuss later that interact synergistically, not just additively, to worsen health outcomes for people. And this matters because syndemics tend to disproportionately impact vulnerable populations like racial, ethnic, and sexual minorities. So to design an effective interventions, we need to not only recognize one issue, we need to recognize that some populations may be at the center of that Venn diagram and have multiple epidemics or syndemics affecting them at the same time. So then we had to question why focus on the emergency department. So I was curious about healthcare utilization and where people that were impacted by multiple epidemics were going to get their healthcare. And studies supported that most people first present to the emergency department. Emergency departments often serve as a primary and sometimes the only healthcare contact point for a lot of people living with HIV, especially those that face stigma of substance use or mental health concerns, but go to the emergency department rather than a routine primary care doctor. So because of this, emergency departments have served for a while now as a safety net, particularly for people with multiple barriers to care, whether that be insurance, income, location, or anything of that sort. And so because of that, we found that studying this area would probably be the first chance we get to find these populations and set them up with long-term care. So that was why we were curious about who was going to the emergency room and how often. And then to answer the question of why we were curious about psychological distress, one of the main reasons was because anxiety and depression were heavily impacting this population, which will show up later in the results. And also because something in school I've learned is that when you're screening for something, you want to make sure you're not just screening for something that can't be treated. Obviously, mental health treatment is complex, but we do have different interventions that could hopefully help people. So we're screening for something that if it is identified, people can hopefully get help for. So that leads to our research question of, is psychological distress associated with emergency department visits among men who have sex with men living with HIV who report a stimulant use? So then on to our methods. So just to repeat the goal of the study, it was to assess the relationship between psychological distress, specifically depression and anxiety, and a non-admitted emergency department in the past 6 months. Our population was sexual minority men living with HIV and a stimulant use disorder. We used baseline data from baseline 1 and baseline 2 of the study Dr. Hirschfield discussed before with the START team. We first started by running all the analyses on your demographics, and we excluded anybody who either was missing questions, didn't answer the demographic or the syndemic questions for baseline 1 and baseline 2. So that brought our total population to 295 people. We calculated the ED visits by a self-reported question that asked participants if they've been to the ED in the past 6 months and not been admitted for care. And we studied psychological distress using the PHQ-4 assay for depression and anxiety. Finally, we did a data analysis with a multivariable logistic regression where first we tested for the association between ED visits and depression and anxiety, and then we controlled for syndemic factors and demographics later on. Some of the syndemic factors we were concerned about were intimate partner violence, additional substance use disorders, excluding stimulants, because everyone in the study had a stimulant use disorder. So any person that tested positive for this would have more than one substance use disorder, and childhood sexual assault. So on to our results. The demographics are relatively similar to Dr. Hirschfield, but a little different because we only surveyed people who completed baseline 1 and baseline 2 of the START study. So we had about 53% that were 25 to 42 years old. The majority were white at 65.1%, 23.1% were Black, and 11.9% were mixed or other race and ethnicity. 79.3% were not Hispanic, and 20.7% were. In terms of insurance, 57% had public insurance, 29.8% had private insurance, and 13% had no insurance. In terms of income, we split it up decently even between less than $10,000 to $50,000 or more. And then education, 81% at least had some college level of education, whereas 18.3% had high school or less. These are our syndemic factors we were concerned about. So with depression and anxiety, out of the 295, 173 screened positive for either depression or anxiety, or depression and anxiety. 97 screened positive for intimate partner violence. 135 screened positive for childhood sexual assault, and 231 of the 295 people screened positive for having more than one positive substance use disorder. So this has a lot going on, but the main things I want you to focus on are this top line here, as well as in the green box are our syndemic factors. So here in the left column is our unadjusted odds ratios before we accounted for syndemics and demographics, showing that depression and anxiety had a positive odds ratio of people going to the emergency department more often. And even when we accounted for the syndemic factors like substance use, intimate partner violence, and childhood sexual assault, it maintained its significance. The other syndemic factor that maintained its significance was childhood sexual assault, which before and after accounting for demographics and syndemics was significantly associated with visiting the emergency department, whereas having substance use disorders, intimate partner violence, And most demographics, even insurance status, were not associated. There was an association with Black participants being less likely to visit the emergency department, regardless of confounding variables. So that brings us to our conclusions. So psychological distress was associated with increased ED visits among men who have sex with men with HIV and a stimulant use disorder. This association remained significant after controlling for other syndemic factors, and other syndemic factors, with the exception of childhood sexual abuse, did show reduced significance. This matters because syndemic theory reminds us that these overlapping conditions aren't isolated. So they interact and amplify one another and act synergistically. So the ED is a primary point of crisis, like I mentioned in the introduction. So it's an opportunity to intervene early and redirect these patients for sustained care so that we could hopefully combat more than just the reason they're going to the ED, but the other issues that they're more likely to be facing. Some limitations were the reduced sample size because of the fact that we filtered for baseline 1 and baseline 2, and limited temporal data because we were interested in seeing if patients who had syndemic factors had an increased frequency of visiting the emergency department. A lot of participants did not disclose how often they visited the emergency department. They just said that they've been. And then future considerations are studying how trauma-informed care, specifically for HIV-positive men who have sex with men, addressing things like childhood sexual assault, substance use, and other syndemic factors, could possibly reduce their visits to the emergency room, which would not only provide them with more long-term care, but it would also alleviate some of the burden on the ED to allow opportunities for other people to get in and get help. I wanted to thank Dr. Hirschfield and Dr. Diaz for being my PIs throughout this. They've been a great support and I've learned a lot. I want to thank the START team for letting me use their data, and Dr. Booten Foster and the STRIDES team here at Downstate for supporting me through the process. These are some of my references, and that is the end of the presentation.
Perfect. Thank you very much. Next, Jillian.
Okay. Hi, everyone. So I'm here with my two other group members, Kellen and Erin's going to share her screen, and we're going to be presenting our research poster. Okay. We can see the screen, so we're good to start. All right. So we'd just like to start off our study by sharing a quote from one of our other group members who couldn't make it here today, but these words powerfully reflect the heart of our research and the power behind our study. So here's the quote. As someone who stutters covertly, I was never offered the chance to attend a support group growing up. I often felt anxious, self-conscious, and unsure in social situations, despite my stuttering not always being outwardly noticeable. If someone like me experienced that level of discomfort, imagine how isolating it can be for others whose stuttering is more overt. So this quote challenges the idea of stuttering immunity, the belief that some people are unaffected by stuttering simply because it may be less visible. But the truth is, stuttering exists on a spectrum, and regardless of how it presents, it can deeply impact the confidence and social participation of individuals who stutter. So with that, our research is titled The Impact of Stuttering Support Groups on the Confidence to Participate in Social Situations for Adults 18 Years and Older. So this explores how support groups foster connection, belonging, and confidence among adults who stutter. So to start, just to give you a little background on our study, there's limited research on how stuttering support groups influence the confidence of adults 18 years and older in social situations. So stuttering involves disruptions in one's speech, such as repetitions, prolongations, and blocks, which can affect communication and confidence. Support groups offer a safe and understanding environment for people who stutter. So studies suggest that various groups, such as the National Stuttering Association, Friends, and Speak Easy International, positively impact individuals by reducing the negative effects of stuttering. So with that, our research question is, how do stuttering support groups impact the confidence of adults ages 18 years or older in social situations? So the impact on the target population revolves around the support group participation, as it appears to increase social confidence in adults who stutter, aiding them in engaging more comfortably in social situations. So to get into our method a little bit of our research, so we utilized a mixed methods survey, and it was created using Qualtrics. It featured 23 questions, 9 of them being demographic questions, in open-ended, closed-ended, and Likert style formats. So the survey was distributed via Facebook, stuttering support groups, and researchers' social medias from October 24th to March 25th. October 2024 to March 2025. And of the original 23 respondents, only 6 met the study's criteria and were included in our final sample. So if you look below in the method section, the first graph that's there, it represents our age distribution of our participants. So as you can see, most of the participants were in the 50+ age group, 66.7%, while 33.3% were under the age of 40. And then below that just shows our participants' race and ethnicity distribution. So as you can see here, 66% of our participants were white, 17% were African American, and 17% were Jewish. And now Erin is going to go into our results and data.
Okay. Hello, everyone. So for our results, we're examining how adults felt about participating in various social settings after attending a stuttering support group. So the first graph you see in the results section shows self-reported likelihood of participation in social situations rated from 0 unlikely to 5 extremely likely. So overall, participants reported high comfort levels across most everyday work settings, including work, parties, and restaurants, which all had a median rating of 4.5 with narrow IQRs indicating consistent confidence. Community events had the highest median score of 5, though with slightly more variability, suggesting that while most participants felt confident, a few were still hesitant. School settings, however, had the lowest median of 4 and the widest IQR, reflecting the greatest variation in comfort. So these differences likely reflect varying communication expectations. So in work settings where interactions is often required, participants may feel more prepared or motivated to engage. In optional environments like parties or community events, people might feel freer to stay quiet, leading to slightly more variation. School settings, which often allow for more passive roles, may make it easier to withdraw, explaining the wider range of comfort levels. And then moving on to our second graph, we looked at more complex or high-pressure social contexts. So family gatherings had the highest median score of 4.5 with a moderately wide IQR, suggesting generally high comfort with some variation. Public speaking events had a lower median of 3.5 and a broader IQR, indicating more variability in confidence. And then for networking events, it showed the lowest median of 3 with a wide QRI, reflecting diverse experiences and lower overall comfort in these professionally demanding settings. So in summary, while support group participation appears to boost social confidence, the degree of the comfort still depends heavily on the nature of the setting, particularly whether participants feel optional, expected, or high stakes. So for our third graph, it's down here. We conducted a sentiment analysis of open-ended responses. These results showed that participants expressed neutral sentiment regarding their confidence in social situations after attending the stuttering support group, but overall no negative responses were reported. So overall, our results showed a positive correlation between attending stuttering support groups and increased confidence to participate in social situations for adults who stutter. Participants valued support groups as safe environments to share experiences, make connections, and build social confidence. And now I'm going to hand it over to Kellen, who's going to go into our limitations and discussion of our study.
Okay, so previous studies like Herring et al. 2022 have shown that support activities for stuttering can reduce its overall adverse impact. Our results align with Tricon and Tetnowski in 2011, which show that support groups may improve communication skills and overall quality of life. Our participants told us they attended support groups to feel seen, make friends, and connect with others who truly understand their experience. Overall, we found no negative effects were reported. There was a general positive impact on confidence in social situations, but the effect may vary depending on individual circumstances and contexts. So moving on to clinical implications. Our study found a clear link between attending support groups and increased confidence in social settings for adults who stutter. So why do support groups matter? Well, they offer a safe, judgment-free zone to share experiences, connect with others, and build social confidence. We as a group recommend including support group participation as part of a comprehensive treatment plan to support both communication skills and emotional well-being. For our limitations, as you can see, we had a smaller number of participants who fully completed the survey. Our open-ended questions may have contributed to this, but they also gave us richer, more personal insights into our participants. Participants also had experience with both virtual and in-person groups, which may have influenced their responses differently. So that brings me into my next point. For future research, we should really compare virtual and in-person support groups to highlight the differences in effectiveness and accessibility. It would also be valuable to compare confidence levels directly before and after attending a support group to measure the impact more clearly. And lastly, exploring how gender might influence individual experience and outcomes could also be beneficial. So just to wrap up, our study found a positive correlation between attending stuttering support groups and increased confidence in social situations for adults ages 18 and older. While the trend was generally neutral to positive, the impact likely depends on individual experiences and personal context. The findings provide meaningful insight that can help encourage more individuals to consider attending and participating in stuttering support groups. And we just want to acknowledge and thank the World Stuttering Network, Space to Stutter, and the Stuttering Community Facebook groups, as well as our participants. We'd also like to thank Professor Kling, Dr. Fabus, Dr. Slavic, and Dr. Fortuno for their support and guidance throughout our research. Thank you.
Well, thank you very much. Thank you all for your amazing research, very interesting. So now we're gonna open to questions, and first of all, you can ask questions to one another if you want. I'm just gonna start with one question. In fact, when Sabina was presenting, I was wondering whether there might be an effect as well of mental health actually on the adherence to the HIV treatment. And in fact, I was pleased to see that this was a topic of, I mean, at least the mental health was a topic of the Michael's presentation. So that would be my question. So you think that possibly mental health could also have an effect of both the methamphetamine use and also the adherence to treatment?
Yes. So the data that I'm reporting from was a screener survey. We had, I think, like 7 surveys throughout this study. So we had like the data that Michael reported on is from a subset of the people who were eligible, who then consented to enroll, completed a dry blood spot so we could measure their viral load, and then completed 2 baseline surveys about 1 week apart. So there were a lot of, and had a Zoom appointment. There were a lot of steps, and we found that I've never had to work so hard on a team. There's like 20 of us. It was more work than we thought because the literature a lot of times excludes people with stimulant or other substance use disorders from research because it's harder to get people to engage. And indeed, we had to enroll before we randomized. We had to enroll about 500 men to randomize 285 to follow for a year. So it was a very big endeavor, and there were a lot of medical students who helped us along the way, and Michael has been fantastic. So yes, mental health was not in the screener, sorry, to answer your question, but it is in all of the surveys once people get into the study.
Great.
So we haven't
Thank
answered
you.
the question yet. Yeah.
Thank you. So, first of all, I want to open the floor to questions, including from panelists to other panelists. So you can just unmute yourself. Yeah, okay, Jose.
Hi, good morning, everyone. Good morning,
Good
Sabina
morning.
and Michael, who I know very well, but good morning, everybody else. I had a sort of broad question for Xinhuan and for the students from Stony Brook. I wondered what the potential policy implications could be for your research, given that either, Xinhuan, yours is very much the implementation of policy, and for the folks that were presenting on stuttering and stuttering support groups, how, at times inaccessible things like those can be to certain populations who are experiencing stuttering, particularly those that are lower income, that might have more barriers to actually accessing that sort of positive social support. So I was wondering for the both of you separately, what the sort of policy implications are and what of the research that you're doing and that you might foresee.
Okay, thanks, Josie. For my research, I think there are two very important policy implications. The first one is that in the solar transitions of China, the Chinese government should have more public participations in the decision-making of the solar policies. China is authoritarian state, and in the current renewable energy policies, there's a little participation from the public, I think. So this is a very important part to have more public participation, either from the environment NGOs or from environment science, social scientists or from local communities. So these voices are very important to be heard. That's the first implication. The second policy implications, I think, is that when we are doing the energy justice research, or when we think about equality or justice, we have to include more like language and ideas of justice to speak back to the current dominating discourses from the literatures or the policy or the policy making process, because I think from the social scientists, this more situated knowledge is very important to recognize the different voices, either from China or Africa or South Africa. So I know, so there's a trying to more a trend in my field to speaking back to the dominant Western ideas of justice. So that's the second implication.
Hi. For us, for policy implications and barriers, there can be multiple. So like limited access to technology. Further, like a lot of the stuttering support groups we found are via like Facebook, and then that's how they get the word out about them. So having that limited access to technology can be challenging, as well as like a lack of awareness and stigma towards stuttering specifically. So yeah.
Yeah, thank you both. I don't want to dominate the time. I do want to say that, even accessing things like stuttering support through Facebook, a lot of younger folks don't use social media like those of us old folks have historically done. So, what the shifting sort of landscape might look like for access to those groups down the line might be something interesting to think about as well. Thank you both for your responses.
Thank you.
Thank you. Is there any other question from the audience or from the panelists?
I mean, I can keep asking questions if nobody else.
Yes, please.
So another question that I had, Dr. Hirschfield and I, Dr. Hirschfield has been one of my mentors, but now we sort of co-mentor a number of folks, including Michael. One of the things that we are very interested in is the mentoring relationship and sort of how mentors have helped and sort of brought folks who are interested in research ideas to the stage where they're able to ask those questions and analyze those things. So I was wondering if you had any thoughts on, sort of mentorship and how mentorship, whether it's related to health equity or equity in general, whether it's related to research, sort of aspects of mentorship that you found positive, aspects of things that you think that students might benefit from in the future in terms of research mentorship, any sort of ideas you have about mentorship and mentoring, with the note that these are not critiques of mentors that we've had in the past. These are not negative things. This is more of an idea of, how you can help us to think about how we can mentor students in the future. And if the answer is no, I can just keep talking.
Well, you could also just say very specifically, how did mentorship help you to get to your presentation today? That's concrete, I think.
I can speak on that. So for our mentor was Professor Kling. I believe she's in here somewhere. She is well known in the stuttering world. So having access to her at all times was an amazing experience because it allowed us to get access to things that we normally wouldn't have access to. Like she was able to reach out to other speech language pathologists in the field that are very well known in the stuttering world. So just having that access was amazing, and making sure that your mentor is very well knowledgeable on the specific topic you want to research was extremely helpful.
Anyone else?
I know my mentors asked the question, but I'm still gonna answer a little bit in the sense that I'm a little different in the sense that Dr. Hirschfield was actually my interviewer for school, and then I was really interested in her research, so I contacted her, and I did appreciate Dr. Diaz and Dr. Hirschfield because they entertained some of my completely original thoughts while also helping integrate me into some of their currently existing projects. And I feel like that helped me see how research was already happening to help me support some of the projects that I was able to come up with original questions for. And on top of that, I think I liked having, as a med student, having people on the scientific side, hearing their perspective, as well as I have some clinicians who are mentors and I get to hear their perspective. And I've actually had them cross over and meet each other and work together. And so hearing how they all collaborate with each other has really helped me.
You don't get extra points for that.
And then I would like to follow up on this question. What has motivated to choose a particular research that you are undertaking? Understand the mentor, personality and importance in the field is an important factor. But are there any other factors? What drove you and to do the research that you are doing right now?
I can go with this question. I think why I want to do this kind of research is when I was preparing for my qualified exam and reading the literatures, I found that there's a highly dominated discourses in my current field that the under the current understanding of justice or equality is highly dominated by the John Rawls idea of justice. So build on Rawls the theory. So and some researchers, especially South Africa researchers and South America researchers, they're trying to speaking back to this kind of Rawls idea and call for more situated knowledges and understandings of justice. So that's as a Chinese, so that's why I'm thinking about how I can think of justice from the Confucius traditions, from Confucius philosophies. So how does this ideas of Confucian sense of justice is rooted in the Chinese modern societies and in how it is embodied in China's current energy transitions. So that's why I want to study the Confucian sense of justice.
Yeah, I found that really interesting, what you said, to kind of think that even the concept of justice, equity, it's maybe culturally different, in different cultures. So I found that very interesting. Thank you. Any other suggestion about or comment on why you chose a particular research topics that you are so passionate about?
I can add. So for our group, as I mentioned earlier, one of our group members has a stutter. So we felt that besides the fact that there's limited research on stuttering in general in the field of speech language pathology, We felt especially connected to the topic as one of our group members is a stutterer. Additionally, we, as future speech language pathologists, it's our role not only to implement direct treatment like strategies and modification for stuttering, but as well as the emotional counseling aspect of it as well, and just learning a little bit more about how people who stutter thrive in certain situations.
And I can go next. So I am very interested in studying sexual health. And I think this is a really interesting time to study sexual health because we have an older population of LGBTQIA plus people who are out for one of the first times in history, especially after the HIV crisis. We have people who are LGBTQIA plus in their 60s and 70s and 80s who may or may not differ in how their sexual health functions, especially with coexisting comorbidities, possible surgeries, hormones, STDs, STIs, and it's a population that I think has not been tapped into, but needs to be studied because sexual health is important for everybody. And I think there's a lot of room to grow in the area.
We need to
Thank you.
resubmit that grant. Yeah, we wrote a grant across departments with urology. So yeah, I mean, the thing is, when as a mentor, when you give your mentees the power, or you empower them to do things, they really can do anything. It's wonderful to see the accomplishments.
Yeah, and they often come up with ideas that you did not have. So I think that's very enriching for us as well. Okay, anything else anyone would like to add? Okay, so I don't see any more. Oh yeah, there is a message. Let's see. Oh, thank you. Okay, so we're gonna close this panel. So thank you for all the panelists, all the mentors, and all the audience as well. So we did an excellent job. It was very interesting. Thank you very much. Bye.
Bye.
Bye, thank you.
So next we have a lunch break until let's see.